Ma'am, so I'll start with the introductions then.
Sure.
Okay. So thank you, everyone. This is the fifth case discussion in progress that we have now. Thank you for the support. Thank you for coming out on Saturday evenings to participate in discussions and to just learn and grow with each other. So today we have Sanghi ma'am with us. She has been ever so eager and excited, ma'am. It was so nice to go through the case with you as well as the whole discussion. So I'll just share the. So okay, so this is the fifth now. So again, thank you very much for the community support that I've been specifically getting. Thank you for the encouragement. Thank you for coming, willing to come and discuss here. Thank you for all those who have been agreed to be speakers and come on the dais here to talk. So today we have Sanghi ma'am. So for the western bit of this country, I know she does not require any introductions, but even 10 years post her retirement, she agreed to do a clinical case discussion, which is so much fun. So she is now honorary consultant at a multi-speciality hospital, Shri Guruji Rugnalaya at Nashik since 2013. She has been the assistant professor for more than 30 years at the Audiology and Speech Therapy Department at TN Medical College and BY Nair Charitable Hospital in Mumbai. She superannuated in 2010. She has been the international representative for India at the International Cluttering Association till 2017. And her present work includes management of individuals with neurocommunication disorders, swallowing disorders, voice disorders, as well as fluency disorders. So, ma'am, thank you so much for agreeing to do this. Apart from just being fun and helping us to grow, your insight means a lot. And at this stage, you're still clinically practicing with small children, and that definitely helps them also to such a great extent. So, ma'am, over to you.
Yes, thank you, Debusmita, for in the first place inviting me. And I'm so happy that young ones are still eager to learn. And of course, with the experience of all the seniors, there is a lot we can learn. I mean, I still learn from my seniors or even my juniors because, there is no such thing as senior and junior. There is a lot we can learn from each other. And so I'm so happy, Debusmita, that you've started this case discussion series. And I think it was the need of the hour because, we get tired of all the typical other presentations, and this becomes very, very useful clinically because basically we are clinicians and we need to improve our clinical skills. So I think that's a great job you're doing. Congratulations for that. And let's begin with this. I'm sure most people are all set to listen for the next half an hour or so, and then maybe we'll have a nice interactive session after that. Okay. Okay. So this title, Establishing and Reinforcing Fluency in a Child with Stuttering, we'll discuss why this title at a later stage. But let's begin with the first introduction. Debusmita, we can have the first slide. Yeah. So this is a very important statement. Like, ask any child development expert and they will tell you that children do not develop in a straight line. There are no average children. There are no standard children. So basically, it's not surprising when you read such statements, particularly we as clinicians, because we see so many children and every child for us is unique. And undoubtedly, because every child who's born is born with a host of factors within him, which interact with a host of factors outside, that is the environmental factors. So basically, the neurophysiological predisposition that he's born with interacts with the developmental, environmental, and so many factors. So there is a long list, to it. And therefore, every child, next slide, please. So every child, therefore, is unique. There's no question. So in young children with stuttering, we have to remember that when we are seeing him at such a young age, the habit is not deeply rooted, which is an advantage for us as clinicians. And therefore, those habits can be unlearned easily. So we can surely help these children, and that faith we must have in our own clinical skills. So managing these children is both a science and an art. This is a statement borrowed from Dr. Stemple. He always says voice therapy is both a science and art. And I feel actually every therapy that we conduct is both a science and art, whichever disorder you're managing. Okay. So what are we really doing when we are seeing children? Basically, we are trying to, do prevention. And of course, there are different levels of prevention, but so it's important to remember this quote: an ounce of prevention is worth a pound of cure. And therefore, I remember way back when I used to teach in Nair, I used to urge the students to, you know, take up children who come with stuttering problem, because that is the time when you will be able to prevent the other layers which develop for these individuals as they grow older, if they are not intervened with. Okay, so I think we really need to remember to execute an early intervention program with the final goal of prevention. And moving on to the different levels of prevention, you all know this: primary, secondary, and tertiary. So when we are seeing children with stuttering, by and large, we try to do a secondary level prevention, that is early detection and management. But unfortunately, when they come in very late, then it is basically a tertiary level of intervention, basically from adolescent to adults it is. And this case presentation, which I am going to discuss, is actually a secondary level prevention program. At times you feel, oh, he is a well-established, but no, he basically, I will discuss this later. So this, what I'm going to discuss, is a secondary level prevention, and we will see how it has helped this child to get into a habit of speaking fluently using some techniques which he has learned. Okay, indirectly, of course, but he has. So that's the reason why I want you all to understand. I mean, I just want to discuss with you all that prevention should be our goal, not only for, stuttering, but I think for all the disorders that we see amongst children. The earlier we see, the better, that you all, of course, know. And I want to quote Ria Paul, the next slide, please, that as clinicians, we need to expand our conception of what being an SLP means. What is it? It means not only picking up the pieces after the disability strike, but also working towards preventing them. And therefore, as individual clinicians, we should always be alert and try to guide people around us to bring the children as early as, particularly pediatricians. If you can talk to them, I'm always having a war of words with my pediatrician in a hospital presently, because Nasik, the awareness is quite poor amongst even the doctors, unfortunately. And therefore, we really need to, and I'm trying my best to do that here with all the doctors by presenting, by, with the WhatsApp group nowadays, I keep sending some patients pre and post, and, that is helping us get more awareness, right? So with that, now we will start with what's happened. Something has gone wrong. Yeah.
Okay.
Okay. Next slide, please. Yeah. So this is a child S who was around 5.5 years old when he reported to me with the complaint of, next slide, please, with the complaint of inability to speak fluently. So as the protocol goes, I was doing his history and was trying to understand the general health and development in this child, because when we do a history, it helps us understand the particular problem in a larger context. And very rightly so, when I asked the mother about the developmental milestones and what she felt about him, she said, we find that he's not as par with the other children in terms of his motor abilities. He gets into a bus with great difficulty as compared to the other children, and he needs help in activities of daily living. So, next, I referred them to an occupational therapist. I said, I think it's better that you get a assessment done, and then we will probably be able to understand his challenges better. And this was the report given by the occupational therapist, that he has difficulties in the areas of sensory processing, gross balance, and fine coordination. Needs assistance with pre-writing and writing skills. There is difficulty with processing perceptual skills, and activities of daily living also need assistance. So naturally, I asked them to go for occupational therapy, which they rightly managed to get an appointment with my assistants, and then they started going there, and simultaneously I was seeing him for therapy. So next. So I continued, of course, like we all say, assessment is not just one session job. So as and how I was seeing the parents, I was finding out the history, and there was no family history. And we always try to find out whether, if there is a family member, whether it's persistent or the person has recovered, the adult in the family. And the relevance of that, of course, not for this child, but as clinicians, we all know that if it is recovered, then there is 65% chance that this child will also follow the same pattern. And if it is persistent, then there is 65% chance that the child will continue. And so our therapy has to be very, very intensive for such children to teach him good behavioral techniques to modify his stuttering and make him more confident as a child. So that is the relevance for our asking about whether the stuttering is persistent or recovered. And now in this child, the onset was gradual. It was not sudden. If it is sudden, we always try to find out what event triggered it off. Was it the birth of a sibling, or was it some death in the family, or any other major event? So that gives us clues about why the child is having these problems. Next. The duration since onset. That's again a very important criteria for us to decide whether we want to start therapy or not. See, there is, in this child, he had dysfluencies for almost 1 year before they met me, and it was increasing. And so the reason why we need to do this is, see, of course, in US and all, they have insurance payment. So they have to give the answer as to why he needs to be taken for therapy. And so the criteria basically is very often that we don't need to spend, meaning the clinicians need, the clients don't have to spend too much, or even the third party payment, they don't have to pay. So we don't want to load them with that. And therefore, the criteria is that if it is just a few months post onset, then we can just do counseling and wait for some time and just monitor the child's development. So that is the reason why we need to know whether he needs to be taken up for therapy immediately or not. Now, this child definitely had his dysfluencies, which had increased over a period of 1 year. So no question of not starting therapy. We had to immediately start therapy. The emotional factors in this child, that he was highly emotional, very sensitive, And that was something that we had to discuss with the parents. The parents had specific concerns that, there was change in the family constellation, grandparents were no longer with them. Secondly, the maids who were with them kept changing every few months, and that was a big challenge for the parents and for the child. The child used to get attached to a particular maid, and then she would leave, and that child would definitely have a lot of uh, emotionally he would be disturbed. And basically this particular change in family constellation, of a change of mates, particularly for this, it happened so that the mother always was traveling or was working, so leaving the child with the maid was the only option they had. And so there was always a problem, and naturally the mother used to be very tense also. So that's another factor which contributes to the development of the problem. So next. So then we always see the video recorded samples, which is representative of the problem. So just one recording doesn't help. We have more than 2 to 3 recorded samples over a period of 2 weeks. And then we get to understand what is the level of the dysfluencies and what secondary characteristics the child has. And we also try to understand whether the child is aware of his problem, what does he think about his problem. But fortunately, this child was not at all aware. There was absolutely no avoidance. He wouldn't even question about this uh, dysfluencies that he was experiencing. So that was one of the very, very positive point about this child. Next. Yeah, so this is the pre-therapy recording. Just
Yes,
one
ma'am.
recording we are sharing.
Yes, ma'am. I'll just stop this share and I'll play it through the VLC player, basically.
Yeah. So basically, I will just tell you what are the different secondary he has dysfluencies almost every second word or third word, and this was there throughout. So though this is a small sample, but every time I interacted, this is what was seen.
Red fruit till mango because it is oval in shape. It is sweet and tang. It has vitamin C. It is oval in shape. I love mango shake and mango ice cream.
Very
We
good.
get mango in which season?
Summer.
आराम से आगे देखिए.
We get a mango in summer season.
ठीक है. अभी
Very
that
good.
Ma'am, we'll just get back to the presentation.
Yeah. Next, I have the secondary characteristics, which, of course, unfortunately, cannot observe that this a lot of teeth clenching. He had his head movements, his hand movements, and his facial contortions. And as you could hear, that the number of dysfluencies, every second word, third word, he was having severe silent pauses before he would say things. So, yeah, move on to the next slide, please. So the stuttering like dysfluencies, they were definitely more than 5%. Tense pauses and prolongations, this is quite obvious from the recording. And the secondary characteristics, head jerks, teeth clenching, blinking, continuously blinking, head turns side and upwards, tightened arm movements, and lips pressed. So these were the host of secondary characteristics he had. Next slide. Yeah. So after, the entire evaluation over a period of a few sessions, I had to answer the following question. Is the child normally dysfluent and has no stuttering? So no question, that definitely no. Is the child at risk for stuttering? Yes, he is at risk for stuttering. But if the child did not have these number of dysfluencies and secondaries, then and if he had just normally dysfluent uh, speech, then there is. But if the child has a positive family setting, greater exposure to negative speaking environments, and presence of phonological disorder, then I would say yes, he's at risk for stuttering, even if his speech. Okay, so this is what we need to remember. And then I would say yes, the child is at risk for stuttering. But in this child is showing signs of a well-established stuttering problem. Okay, child has secondaries, fear, and avoidance. Luckily, like I said, he was in that sense unique. He had a lot of secondaries, but had no fear and no avoidance. Okay. So move on to the next. So like I said, my decision was that he's showing signs of a child with well-established stuttering, but yes, no fear and no avoidance, which was a positive thing for us for me as a clinician and for the parents. So move on to the therapy that I initiated. So basically, we always start undoubtedly with parent counseling. And I did the parent counseling over 2 sessions. And the parents were surprised that, there is so much that they need to do and not do. Okay. And so they were very happy that they got to know so many things that they were doing. They had to stop doing those things. And so it's crucial. I'm sure all of you will agree with that. And are we making the parents feel guilty by telling them these do's and don'ts? That is something some people feel. I personally feel, and I think most clinicians feel, that if you tell the parents that, see, as parents, you are trying to follow the best child rearing practice. But sometimes unknowingly, we are doing things which is not a very good thing for the child's fluency development. And therefore, and not that every child will have these problems when parents are doing these things, but your child has this tendency, he is sensitive and he's had these other issues. So I think what I'm going to tell you now, I just want you to understand that these are things which you have not done intentionally. It is just that most parents would do this. But because your child has this challenge, we need to be a little careful and just follow these do's and don'ts. Because basically, our aim is for the child to experience fluency, and that should increase day by day. And for that, we are going to do a lot of things. And one of the things is, as parents, what you need to follow. Okay, so next slide. So these are the do's and don'ts. So do not impose verbal demands and verbal displays. Again, parents want to always make the child confident. So talk in front of strangers, in front of guests. That is always there. And I always say that right now you have to give him a break. Do not make him talk in front of people. Don't force him. If he talks, fine. Now, in this case, in this child, this was not a problem because the child never bothered. He would speak whenever he went, whenever he was asked to. He wouldn't bother about his dysfluency. So, and this is very important, that do not expose the child to a hurried lifestyle. Today's time, it is difficult to follow this, but we have to tell parents, try your best to make sure that you're not following a very hurried lifestyle. Don't put him into too many classes. Don't, in the morning time, hurry him up for everything. Wake him up a little early. Even parents need to go to bed early and wake up early for this to happen. And so a lot of things that they need to do to make sure that the child is not exposed to a hurried lifestyle. And yes, not to contradict the child for everything that he wants and everything he says. you have to handle that very, very tactfully. Do not interrupt the child for obvious reasons, as you all know, and we have to make him speak at his own pace. Do not have heated arguments in the child's presence. Now, why is that? Why do we say that? It's because when the parents are arguing and in a heated argument, the speech is not very pleasant. The speech is not slow. The speech is something that the child need not listen to at this stage, because he is always following the models that he sees around him. So particularly when they keep having these heated arguments all the time, and more so with the idea of what the mother should allow the child to do and what not to be allowed, or vice versa. So the father says, no, let him do, and the mother says, don't let him do. So this is something, a big no-no, because the child gets confused. He doesn't want to see this kind of an argument about what he should do, what he should not do. Okay. Then the negative comparisons. The child need not be compared with his cousin, with his brother, with his sister. Like, see, and I always tell the parent that you are doing it with the best of intention to motivate the child, but it does not work with every child. Some children will take it up as a challenge and do it, but some don't. So don't take that risk. Do not do any negative comparisons. In fact, you compare his own behaviors with the earlier behavior. So if he has done something nice compared to the earlier time, say that to him, and do not do negative comparisons. And repeated corrections for his speech or for anything in his habit need not be done repeatedly. I always say, take every 2 weeks a small play session with the child and then tell him about, see, these are very good habits you have, but certain things you need to change, and we should try and change this and change that. So there are different ways of doing these corrections, which we can discuss later on. Next slide. It's already 7. Okay. So we ask him questions very often, which will require a long and complex answer, sentence structure. So we try not to. I tell the parents, do not ask him questions where he has to answer a long question, long answer. So let him answer in yes and no, that's fine. Or force him to enter a situation he's fearful of or reluctant to, for obvious reasons, because we are trying to make the child bold, but with that fear in him, he's likely to experience more of dysfluencies. Again, insist on confessing a wrong he has done. Why? Again, he's going to experience more dysfluencies. So we are taking care that wherever his speech is going to become dysfluent, we try to avoid those things. And obviously, do not make him talk on the days he's experiencing dysfluencies. Every parent will say it is cyclic. So whenever he is in the bad phase, tell them not to ask him questions. They should do the talking, and vice versa. When he's on his good days, then they should talk to him, make him, talk, ask him a lot of questions, so that he's experiencing a lot of fluency. Yeah, next. So now coming to the do's. So obviously just the opposite. So be a relaxed listener. You're not going to interrupt him. Let him complete whatever he has to say, and be a relaxed speaker. So you are speaking very fast, but you're expecting the child to speak slow. That doesn't happen. Make speaking a fun activity. I'm going to tell you some activities later on. So I tell the parents to do those. Then build on your child's confidence in all areas, not necessarily in speech. So if he's good in drawing, let him do drawing almost every second day, and then praise him, put it up on the board and show it to the family members, show it to friends in his presence. So he starts getting that recognition that, oh, he has some good, habits and some good things in him. So that is, and this is very important. Speak in simple sentences at a slow rate, maybe stretching out the words a little and using a pleasant melody. This definitely helps children, because that's a good model for the child to imitate. Yeah, next. These activities are a must, I feel. Reading to the child in a relaxed manner. I always tell mothers that, you should finish all your housework and everything, and then in the afternoon or in the night, you be relaxed, because unless you are relaxed, you're not going to be reading out in a relaxed manner. Then describing pictures again in simple sentences at a slow rate. Then making him recite poems with appropriate gestures, because I have seen very often the child is rattling off the poem at such a fast rate that you sometimes don't even understand. It's all cluttered together. So, because he just wants to finish off what poem he has learned. So we have to make sure that they are exposed to poems which are, I'll have a recording later on for you all to listen to that. And encourage him to talk on the days he is fluent. Just like we said, don't make him talk on the days he is dysfluent. So these are simple things which the parents need to follow. Now, very often parents do not follow this. And I keep telling them to send me recordings of how they are interacting. And even the present child whom I'm going to discuss, the mother had a fast rate, and I would all the time tell her, see, in this recording, how fast you're speaking. So please, so she's a yes, yes, I'm trying my best, So this is what we need to keep monitoring about whatever they are following. Are they doing it correctly, or whether they are being consistent with that or not? Okay, next. Now there is this concept that we should not discuss this in front of the child. We should not say that he has any problem. Yes, sometimes it is good to not discuss and use the term stuttering, and it's very difficult sometimes to even judge whether the child is aware or not, And of course, the child is going to be aware. He knows that he has some interruptions as compared to the others. But Van Riper's suggestion, which I always think is so correct, that it is better to discuss the problem using a simple language, because otherwise the child feels that I am having a problem, but mommy and daddy, they don't even talk about it. And they may feel that there is something that's happening. So that's why he's labeled it conspiracy of silence. So we don't want the child to go through that feeling that there's something wrong with me, and it is so bad that they don't even want to talk about it or discuss it. So we should always say that, yes, your speech is bumpy, and some children, they have it when they are learning to speak. And like when they come for therapy also, we always say that, see, you've come here to a speech school because your speech is bumpy. And like some children, they can't write well, or some children who cannot draw well, then they go for drawing class, right? So you've come for a speech class to improve your speech. And I think that's how they accept it in a better way, when it's the way you explain to the child. And we always tell the parents to use simple words when they're describing the child's speech. Okay. So moving on to the approach that we have to use. Of course, with him, I have used a direct treatment strategy, because I had to work with his speech behaviors. And initially, it was more working on his speech behaviors versus modifying his stuttering movements. So, and luckily it happened to him gradually. It is happening that he's modifying his blocks on his own with the techniques that we have used. And as you will see it later on. So moving on to the approach, which was actually suggested by Cooper. Okay. So it is known as the ABC approach. So affective behavioral cognitive approach for a child with a well-established stuttering. So I've used this. I basically use a combination. So like integration of different approaches for a given child. It might be different for another child. Like I discussed, every child is unique and it's never going to be one size fits all. So we have to be always using modifications to our therapy program. Okay. So this ABC, the affective behavioral cognitive approach, what is it? Moving on to that, affective basically is where we are going to make the child feel that he can take a control over his speech behaviors. We call it the speech movers, okay? So the vocabulary that we use that, yeah, move on to the next slide, please. So the feeling of control, the child needs to understand. We tell the adults, I always tell the adults that so far you've been thinking these dysfluencies are happening on their own. But now you need to understand that you can get a control over your speech mechanism. And getting that feeling of control is very important for you. And of course, we use different techniques. But for a child, we have to do it in a very different way. But we have to make him realize that he can bring his speech mechanism under his control. And the behavioral adjustments that need to be done to sustain this feeling of control. And for this, we use what we call as the clinician models, and the child imitates. And I like what Tweeters and Guitar, they have given a structured program for this. I'll just discuss that later on. And finally, cognitive, where use of the vocabulary of fluency. It assists in conceptualizing a set of behavioral technique. So what is that cognitive? We have to make a imaginative construct for the child and then, use the different, what do you call it? Tortoise speech or rabbit speech, so we tell slow speech or fast speech. So that kind of concept we introduce for the child. Move on. So this is the basic part. And so now to establish and transfer fluency, this is one of the hierarchy that one uses. And I have used it, and students who have learned from me, I have always emphasized that this is something that it is structured and it can be used with the help of games. That is the best part about this. And I have used it. So many of the clinicians have used it, and we find it very useful because child does. I don't say every child will, but most children, yes. Some children, they will not do this. So, but you have to again make changes in your therapy program if this doesn't work. Now, this is a 13-step program. I will not go into the details of this. I'll just tell you the first 2-3 things. That is, the first one is clinician uses single word at a slow rate, and it's a direct model for the child, and the child has to just imitate it. So you are naming pictures alternately. So you have said you have named a picture, and you have to just tell him that, see, we are going to play a game where I will say name one picture, and then you have to say another picture. And you can have it in a different way, in different forms. I will give you some examples of that. Now, the second one is indirect model, where the clinician, single word, slow speech, indirect model, where here the child will not use the same word, but it's like a box full of objects, and you say, this is a surprise box. I'm going to see what comes in my hand. Say it very slowly. Supposing it is let's say a flower. So you say flower. So you're saying it in a very slow manner, and then you say, okay, now it's your turn. So just see what comes in your hand from the surprise box. And then, he or she will say that. And if he says it correctly, then we say, give him a reinforcement. Then we move on in the sense that we increase the length of the utterance. And then we move on to parents observing and the parents doing it at home gradually. and that's how it goes. So go on to the next this. Yeah. So here it's sentence, slow speech, then here it is conversation, and here it is parent, conversation, normal speech, no model. So later on, even the slow rate is you come back to the an optimum rate of speech. Okay. So this is how it's a 13 step program. You don't have to follow it very strictly. With every child, it can vary. So it's with experience that you will get this know-how of how to implement this. I don't know. I'm sure some of you are listening have already used it. So anyway, so basically, I want to give you a few examples of games. Now, you all know that our therapy should be, incorporated with the use of games. Only then children sit with us. So there is this game of frog jump, So you just press the tail and the frog jumps. And then there are different colors in it. So when you're increasing the number of words, then I say, okay, I'm going to say uh, the yellow frog jump. So 3 words, yellow frog jump. So, the child has to press and that the yellow frog jumps. And then you tell the child, now it's your turn. You tell me and I will press the one which you want me to press. So this is just an example, but there can be so many, even catching the fish game. There's so many games. I'm sure you all have better ideas, but I'm just giving you a few ideas which I have used. Move on to the next slide. This is another very, very important thing I had said earlier also. Use a lot of rhythmic activities with children, because that is where the speech will have rhythm. And we all know stuttering is a disorder of rhythm, and therefore you must give this importance. So activities like bouncing a ball in unison with speech, tapping and using speech, marching, and poems. So here I have one example of a poem, how it is slow with good intonation, and how if the child listens to it and if he is going to imitate that, he's going to experience a lot of fluency. So all these activities are for the child to experience fluency at the initial stages, and this should continue all the time, I feel. Okay. Move on. Yeah. I cannot hear you.
Ma'am, so I'll just share the elephant song right now then.
Okay.
Okay, ma'am, 1 second.
So basically, any poem, I feel, needs to be said at a slow rate, and use the appropriate gestures, because when the child is using gestures, he'll automatically slow down, So
मैं नहीं गा
एक मोटा हाथी घूमने गया, मकड़ी के जाल में जाके वो फंसा। जाल को देखा, देख के डरा, दूसरे हाथी को इशारे से बुलाया, इधर आ, इधर आ, इधर आ। हा, 2 मोटे हाथी घूमने गए।
yeah.
Ma'am, should I play the other one also?
No, it is this. It is a continuation of the same one, but I just
Okay.
wanted to emphasize a few things here. That now it is a very, very long poem. So what we do is, as usual, ask the child to say the last part of the. So idhara, 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 ha. So here again, he's prolonging and saying it. So you have to use such strategies where the child feels that he is taken part in that. And of course, an older child will be able to say the whole thing, and with gestures that will help the child to go slow and in that intonation pattern. So that's important. So I shared this audio with the parent, and I asked her that you have to use this kind of uh, recitation of the poem, and use many more, So this was an example for the parent to follow. So I think we need to give them, by just telling them do this, do that doesn't work. We have to give them examples. Okay. Move on to the next slide. This is a hypothetical construct by Cooper in 1991, where he said that this fluency initiating gestures, and he called it a figman. So this particular uh, figure, he called it a fig man, and then he gives a variety of the different speech that modifications of speech behaviors, like slow fig, easy fig, deep fig. So for example, slow fig is the this fig man who is slow, he's going to talk at a very slow rate. So you use pictures, you use a story format where you're going to tell the child the story. For example, monkeys and the cap seller. So you will say, okay, what did the cap seller tell the monkeys when he saw that the caps were worn by the monkeys? So you say that whole sentence, please give my caps back. Now, this can be at a slow rate. It can be at in a loud manner, in a soft manner. So these are all these. So you can, every time you have to use only one fig every session, use another fig at the next session, and you play a game where you say, now you are the fig man and I'm going to listen, and I'm the fig man and you're going to. So in the story format, by making modifications, for example, you can say that, he said slowly, and the monkeys gave it back. But when he spoke very fast, the monkeys did not give it back. That's what I have heard from my mother. So you have to make a few alterations and, do these kind of activities. So basically, this is a hypothetical construct. I have used it with this child and he enjoyed it thoroughly. Every session I was using a different fig man. And I don't say every child will enjoy it. You have to try, like I said. Okay, move on to the next. So like I said, figs are hypothetical constructs which help in conceptualizing a set of behavioral techniques like slow, fast, hard, easy, those kind of things. So that's what I have again listed in the next slide, that what are the different vocabulary that you can use for the child to understand what is our main aim here. We are telling, I very often say, your speech movers can be changed the way they speak. Okay, so you can speak fast, so your speech movers, you're making them move fast. Your speech movers, you're making them use slow. Okay, so eventually we're trying to tell the child that your speech movers can get under your control, so he gets that feeling of control. Okay, yeah, next. So like I've already said that an example of loud FIG, we will get our speech movers under our control. We will speak loudly, we will speak softly, and you demonstrate this with the help of a game, which I've already spoken. Okay, so next. You can modify the figman, modify the vocabulary that you're using. These are the different things you can use: fast and slow, tortoise and rabbit, tight and loose, or stiff man and lax man, bumpy speech versus smooth speech, snake speech versus frog speech. There are so many things, and you can be innovative and you can use your own, but you have to be playing with the child, using different vocabulary. You have to be a relaxed clinician while you are with this, I'm sure with most of the children that you are handling. Okay, next. So the activities that in the environment that one needs to use to facilitate fluency, I always tell parents, this is for the parents, that you have to sit with the child on a one-on-one basis, speak at a slow rate with careful listening skills. That has to be an ongoing thing every day. I tell mothers who are working, I say, okay, 15 to 20 minutes every day, quality time, and you are going to do this reading to the child, playing games. So it's a very important part of therapy program. And this is again a very important one. Praise and appreciation should be in the ratio of 3:1. That means if you have corrected the child once, or if you have, all the time contradicted the child about anything, but there should be, in proportion to that one, 3 events where you are going to praise the child, you are going to appreciate what he has said or what he's doing. No, not necessarily for speech. It's always, whatever we are telling the parents is not only restricted to speech, okay? So that is the most important part of the counseling, where you're telling the parents, I mean, I would like to, how much time do we have? I just, one
Please, no, ma'am, take your time. Please,
experience.
ma'am.
Pardon?
Please do. Take your time, ma'am. Please do. Please
Yeah.
do.
So one experience I had just 2 years back, I had called the parents for counseling, and I had seen the child the previous session. He was about 12 years old. So when I was counseling the parents about all these points which I discussed with y'all, so when I said that, you are not supposed to all the time correct the child, and so immediately the father told that, see, Atas to kai bolla hota, ki the mother kept correcting him for everything, na? So he's telling the mother, आई माझ्यात काही चांगलं नाहीये का? तुम्हाला नेहमीच काही ना काही सांगत असते की हे बरोबर नाही, ते बरोबर नाही. See, now that was a very big revelation for the father also, because he was shocked to hear that from the son. So see what the child was going through, because all the time. So at that time I told the mother, see, I know you are trying to be the best mother, but unfortunately, see what is happening. So it was a nice example for me to tell the mother when the father shared this. So what I want to tell you is that every time we often tell the parents that don't. So very often I tell them, you go on, count the number of times you've corrected your child every day, and how many times you're asking the questions to the child, where he has to all the time answer. But as soon as the child comes back from school, you're, asking, what did you do? How did you answer this? How did you answer that? That's a very typical scene. So we have to tell the parents, don't force the child to speak when he comes back from the school to answer all your questions, because he's in no mood. So make sure that he's in a good mood to interact with you, play, and then at a later time, you can ask him whatever you want to ask about the school activities. So this is very important. And I'm telling you, most of these things which I told this particular parent, they realized that they were doing all these things. And that's how the changes that they brought about in the environment. And of course, his occupational therapy, because he had these sensory processing problems and his motor issues. So that also has helped him. So all in all, the entire program has helped this child, and he's still not fully okay. He is. So let's listen to the mid therapy recording.
Once upon a time, there lived a king in Pataliputra. He had illness. One day, one wise man came and invented the game chess for him. And then wise man said, what do I have to give? And then he said, jewels, gold coins. And then the wise man said, you need a 1 wheat for the first square. You need 2 squares of it. You need 2 wheats for the second square, and you need 4 wheats for the second square. And king did it, and And after the time, when the times passed by, the weeds were very short, and then the king said, "Oh no!" And that how was just.
Yeah. So you can not see his secondary behaviors, but they have reduced to a great extent. And his speech, if you have noticed, he was using a few modification techniques. He was slightly using a slow rate for certain words, which he was not coming out with. So he was doing it already by the mid therapy program. And now this is, so I just want to say that I have seen them first in August 22. And just when COVID was, I mean, I think a year after the COVID, and they couldn't come to, they were not from Nasik, and so I was seeing them online. So the entire therapy program has been conducted online, and I was a little skeptical, but it has worked, and the parents are extremely happy with his progress. They feel that from the severe level, he has come down to a mild level now. And if you can see the present recording, the recent one, I think that that will be a little later. Let's go to the next slide. Oh, it's there. Okay. And this is the one now you played, or maintenance? Yeah.
So, ma'am, we played the mid therapy one now. So I'll just go to the next slide then.
Yeah, next slide. So basically, what we do is, after we have established a certain amount of fluency, we're trying to transfer it, which we had already done with this child at home. He was already fluent. Now, basically, I'm working on his maintenance. So I monitor at regular intervals, and we have to see whether the child is using spontaneous fluency or controlled fluency. This child is using controlled fluency. He's using certain techniques to improve his dysfluent speech, and he's progressing. I don't think he's regressing. So you have to ask these questions to yourself. And then you have to schedule sessions for parents and children at regular intervals as the time, as the need is seen. And then you gradually fade off. So I'm already faded off the sessions. With the parents being busy nowadays, they find it difficult to, they are happy that the child is doing well. So they every time tell me, yes, we have to connect, and then they are traveling somewhere. And that's what happens with most parents, I think. So anyway, at least they are working on it, and he is improving. So let's see his latest speech sample.
सुप्रभात, मेरा नाम है शारव। आज मैं मेरा प्रिय खेल के बारे में बोलूँगा। मेरा प्रिय खेल फुटबॉल है। फुटबॉल में 2 टीम होती है। हर टीम में 11 खिलाड़ी होते हैं। फिर क्या, मेरा पसंदीदा खिलाड़ी रोनाल्डो है। फुटबॉल 90 मिनट का खेला जाता है। जो टीम ज्यादा गोल स्कोर करती है वो जीत जाती है। फुटबॉल फुटबॉल 2 हाफ में डिवाइड किया जाता है। डन। मेरा प्रिय टीम जर्मनी है।
मैं फुटबॉल सीखता भी हूँ। शारव, इतना बोलना है सो मत। उठो, मैं रिकॉर्ड कर रही हूँ। मेरा प्रिय टीम
जर्मनी है। मैं मेरे दोस्तों के साथ फुटबॉल खेलता हूँ। मैं फुटबॉल सीखने भी जाता हूँ। धन्यवाद।
Yeah. So as you see, the mother was very, very persistent that he completes the thing where there was no need. And that's what I told the mother. And she says, no, he knows it. And so he should say it and things like that. So that's what happens. So anyway, but as you can see, the fluency has definitely, improved. His dysfluencies have reduced. His secondaries are there with his hand movements, but that's, I think, is fine. But he has no tense pauses now and no facial contortions at all. So that's a good thing. And parents are happy, but I'm still wanting them to work a little more and he can improve further as he grows older, because he's going to have many more challenges as he grows. And so fluency should not break down. So we need to stabilize it, So, okay, so we will end this with this quote. It is easier to build strong children than to repair broken adults. So this was my effort to make this child strong in his fluency, and I'm going to continue to do that. And thank you for listening patiently. I think I've crossed my time limit. That's
Ma'am,
my usual problem. I can never finish presentations on time. So,
ma'am,
okay.
there was never a limit. We were so engaged with your discussion, because apart from the case, you told us so many other things that we most of us possibly be doing, but it was so validating that this should be done. This is how you are doing, and there are results with this. So, ma'am, this is something very small from Insightful Pediatric SLPs for you, for your time, for your case discussion here. And I'll just stop sharing this 1 second. So, ma'am, we do have one thing in the chat box. I will read it out to you. So, like, one size doesn't fit all. Everyone will have his own pace of achieving. So, how do we tell parents about the duration of therapy sessions? Also, is it okay to have sessions once a week, because private therapies become a burden to the pocket? And so we need input.
Can you just, I just want you to tell me the first part. I'm having a little problem understanding the speech. So can you be a little louder?
Ma'am, can you open the chat box in your panel below? You'll be able to read it then.
Yeah, okay. There are only two messages. I can see only three messages.
Ma'am, should I put it up for you?
This is from Sauni. Ma'am, when the child has both misarticulations and dysfluencies, what should you give preference to? Okay. Now, there is always a debate about this, but I prefer to work on both simultaneously. So you work on articulation, you're using language and you're using speech. So, you can work on both the aspects simultaneously. So start with first 2 sessions of articulation, counseling the parents and everything, and then also work on the fluency. And remember one thing, when a child has articulation problem, then the recovery is always going to be a challenge and it takes a lot of time. Okay. So that is what the literature says, that children with articulation problems are likely to, take long to recover. So I personally feel that it should be simultaneous. In the same session, you can do both the things.
Ma'am,
And
this
what
was
was
the
the
first
next
one.
question?
Ma'am,
Like
this was
one size doesn't fit all. Everyone will have its own pace of achieving. How to achieving. So how do we tell parents about the duration of therapy sessions? We cannot, duration meaning the number of total number of therapy sessions,
Yes,
or is
ma'am. I
it,
think that's what it is meant. I think the number of sessions, or if it's for a 6 months, 8 months, or a year, I think this is what is meant.
No, I always tell the parents that it may take 6 months to 2 years also. And of course, we will be fading off the sessions, but we cannot judge right now today that, it's going to be 3 months, 6 months. It's very difficult. We have to see how the child responds, how you cooperate as parents, and how the child picks up. So there are many factors. So I think we cannot tell you right now it's 3 months, 6 months. It's going to take any time between 6 months minimum to 2 years. Like this child, 1 year it took him to get some amount of fluency, but of course he was a little irregular. Mother was working, as I said. She wouldn't get time to connect. She would be traveling, then there would be vacation, they would be going on vacations. But I was not so hell-bent that no, every week 2 sessions. No, I used to sometimes take 1 session a week, okay, and then sometimes 2 sessions a week. But you have to be flexible. As far as the parents are working at home, it's fine. Okay. Also, it's okay to have sessions. Yes, it is okay to have sessions once a week with a proper home program. It will work. Definitely it will work.
Ma'am, so here, ma'am, some children, ma'am, ma'am, if the chat open, ma'am, you can read this
Yeah.
from
Now I
Vedaja.
can see. Now I can see. How does one explain on multilingual environment and dysfluencies across language development? Yes, that is always a challenge. I always tell the parents that you try to use 1, but at the most 2. Don't have so many languages, because that definitely is a challenge for the child. So we have to tell them that the child will learn the other languages at a later date. Right now, you focus on developing fluency for the child. So ideally 1 language, but if not possible, then 2 languages. And in India, it is so difficult to have 1 language, because most of the time children are, exposed to so many languages when they're
Correct.
playing with children, and when they are going to school, and there's 1 language at home. Very often parents are using different languages, so it's parents, in the sense mother uses 1 language, father uses, and mother is very, like in my building I have one, of course not that the child has fluency problem, but she says my child should know Tamil because she's a Tamilian, and the father wants the child to know Marathi because he's a Maharashtrian. So so basically these problems do come up, and I tell them, yes, I do agree, but first few years let him be with 1 language. There's enough of time in future for him to learn so many other languages. So that is what I generally tell them. And about how would you approach discussing character building with parents who are struggling with the question, why is this happening to my child? About stuttering, we can explain, but character building, send them to the psychologist. They will probably help. That's what I would say. And ma'am, parents don't have so much patience. They continue for 2 months, and after that, no follow-up. I agree. I mean, that is happening in many children. So we can't help it. It's ultimately the parents' responsibility to be consistent and follow up regularly. And many parents don't. In fact, I have had parents who come for 3 sessions and they have got lost, And then there are parents who come back after 6 months. They say, sorry, we couldn't follow up and all. And some, of course, don't come back also. So that is going to happen, but we can't do anything about this. It's up to them that they should, take care of this and be consistent with their therapy with the clinician. Don't have so much. Yeah. So I think that was the last questions.
No, ma'am, there are a few more, ma'am.
Post-plan therapy for stuttering children. Best post-plan therapy. Okay, after therapy. So stabilizing, right?
Ma'am, I think maintenance and generalization is what is meant here.
Stabilization. So, I mean, the best plan is to continue the same activities with advanced language abilities, use storytelling then at a later stage, but you have to continue, and that the parents can do. You can see them once a month for the stabilization stage, and so that's how I would do it. How would we tactfully talk about relapse without scaring parents? Tactfully, you have to just say that some of the problems which a child experiences, whether it is like medical conditions, there is a relapse sometimes. So similarly, it may happen in your child. If there are, like this present child, I'm going to tell the mother that, there is likely to be a relapse if he faces some stress in his school at a later age. So what we really have to do is make his speech habits strong. And making the speech habits strong is only through practice. Make him experience as much fluency as possible along with a positive environment. And the child should be experiencing all this to make sure that he stabilizes. So there are different activities you can do for that.
Ma'am, so there are cases where the level of stuttering or the severity, it is constant throughout. And then there are so many cases, it does increase basically. So, ma'am, because, Daniel put up this point about relapse or, it is increasing, uh, children in whom there is a tendency to increase, the severity to increase, ma'am, parents will already, most of the time, they will report that जब चालू हुआ था इतना नहीं था, we saw it increasing, so we know when we stop it or we are not paying that much attention, it is very likely that it will increase. So ma'am, obviously the parent has to be cognizant, the parent has
Your voice is gone.
to... Can you hear me now, ma'am?
Yeah.
Yes, ma'am. So I was just saying that if the parent is mindful to give you this observation, जब शुरू हुआ था इतना नहीं था, वो बढ़ गया, and that's why we have come. So we know when you talk about relapse, that we understand that it is not a medicine, it's not a permanent solution. If we stop coming or we stop
Your
doing that.
voice is going.
Oh, okay. No problem, ma'am. Ma'am, can you read with?
Take a lot
हाँ,
of time to improve from mild stuttering. In this case,
हाँ,
parents expect fast recovery. How do counsel the parents in these cases? So
हाँ,
if the child is taking long, then we have to remember that there are certain factors which are operating, which are, not helping him improve. So we have to do a little more of in-depth, you know,
correct,
inquiry about what is happening, how is it happening. I tell the parents to maintain a diary on the days he's fluent, what has happened, the days he is not fluent, what are the trigger factors. So then you have to keep working on those aspects. I mean, I understand what the issues are. I mean, I couldn't understand the details of what you were saying, that but I understood the first part where you said that the parents feel that when he came to us, he was not so
yes,
severe. Now he has become
yes,
severe. The first thing I would say is that his language has developed. He has, grown, and lot of changes have taken place in his speech mechanism. His tongue and his jaw and his mouth, those have grown bigger.
correct,
His system is maturing, so he has to keep pace with all those things. But I want to understand, why is it increasing? Because most of the time with all these techniques, children should improve. So there is something that is happening which is, affecting his speech, and he's not improving. So we have to again probe into greater detail and try to find out. There are some other conditions which are, trigger factors, and probably we are not aware of them, what he's going through as a child. So I know it's a very difficult thing. We have to then probably take help of a psychologist.
yes, correct,
Okay.
yes. Ma'am, there's another one, fMRI studies on pathophysiology. Are there any fMRI studies?
Yeah, there are some studies, but that is, I'm not aware of it, but I know at one point of time I had read about it long back, and that they do find some differences in the individuals with stuttering, their brain, there are differences, and I mean, that is already proved that, you know, individuals with stuttering have a different neurological makeup.
Correct,
So
correct.
that is there. But see, I always say ki even if you do these tests for clinical purpose, that is not going to help us. What we want is the child needs to develop fluency. So we know he has a different neurophysiological mechanism for his
Correct.
speech. His circuits in the brain are a little different compared to other children. So we have to work on, improving his fluency by using techniques, and that is the only thing we can do. There's nothing much more we can do for these children. It's therapy alone which will help, and of course psychologists help can be sought in such individuals where there are some basic problems and where we are not able to understand why it is happening. Then a psychologist's intervention might help. If a parent is aware that severity can increase, explaining relapse is slightly ever so easy, else it is difficult. Actually, relapse in children, it's likely to happen. I do understand that. And here the question is that severity can increase, explaining relapse is slightly ever so easy, else it is difficult. So it's not, if a parent is aware that severity can increase, explain it is slightly ever so easy, else it is difficult. Yes, I do understand that it is difficult to explain to them and very difficult for them to accept it also.
Correct.
But we have to tell them that, this is one of the problems that can occur, and mainly because of certain stresses that work in the child's
Correct.
life, and that is going to affect his speech. So I think we'll have to accept that, and we have to counsel them. That's all we can do. And we have to tell them, see, you have to be at the whole, you have to follow the main goal in a focused
Correct.
manner of making him experience fluency, reducing the fluency disruptors in the environment, and building up the child's confidence. That is important. And the earlier they come, it is easier. But when they come
Definitely.
late, that is when the problem is.
Correct.
Because already so many other layers have,
Formed.
formed. So,
Correct.
ma'am, I have a similar case as just discussed pertaining to Daniel. And I feel the anxiety of the parent sometimes transfers because the child feels he's doing well and he feels much better, especially kids who are aware, but teachers report to parents impacts, and then that anxiety is on an increase. In this case, parental counseling and teachers need to be, yes, definitely. I very often encourage the parents to talk to the teachers. In this case, I didn't need to because, the child was not experiencing any problem in school or anything like this. So, but if it comes to it at a later stage, I will talk to the teacher also and explain to the teacher what her role will be.
Yes. And ma'am, also older the children get, they tell you so many more things, like you were just discussing. I have a 12-year-old who will tell me, Arey, that was a CBSE school and they wanted us to do JEE in sixth only. Now I'm in this school, it is so much better. I can talk to my friends who are not thinking about becoming a doctor at sixth standard. And it's astonishing at 12 years of age, because the parents are like, Kya banna hai? What do you want to become? What do you want to become? What do you want to become?
Yeah. So it's that, see, now in the present time, there is so much stress parents
Yes,
have
yes,
about bringing, what the child will do, how he's doing in school, and they have their own personal, problems. So it is difficult, very difficult. I don't say it is easy, but like I said, this child, it was we got success uh, till this point. It may not happen with every child.
correct,
So I mean, we have to have that open mind that I may not get success. And we have to be willing to share this with the parent that, yes, sometimes it doesn't work, but, there's nothing else we can do. We have to work on his speech behaviors, modification techniques, and things like that. Like I had another child of the same age before this child. I think I saw them before COVID. And that child's mother was, and the family was so stressed out that there was the child's uncle was having dysfluency. So they kept asking me, see, do you think he'll become all right? Do you think he will outgrow this problem? So I said, see, our attempts will be to ensure that he outgrows, but there are so many factors. But if it does not, then we have to accept and we have to train him to use techniques to modify his dysfluencies.
Correct.
And that is the only answer I said we have. And this child is doing very well. I just spoke about, he's doing well now. He's stabilized almost. And that child, he unfortunately always had adult model. He never played with children. So always adults around him. The only child in a family of, say, about 20 people. So, he had all adult models and
Correct.
his language was excellent. So he faced a lot of problems, and but he's doing well now. So I've told the mother that be prepared that in case it happens, he's getting more disfluent. We are teaching him. I'm teaching him the techniques. I've taught him the techniques. The same thing which I discussed now, and he's picking up. And he now says, yes, my speech movers are under my control. He says that. So he's a smart child, a brilliant child. So he can talk, and discuss with you on so many issues. So basically, these are the problems we face.
Ma'am, there's one more from Daniel, ma'am.
Does RTMS or deep brain stimulation work with stuttering? It's still at the research stage, so we really don't know. And I mean, I have not come across anyone where deep brain stimulation has worked. Actually, it is working in Parkinson's. I have read
Yes.
about that.
Yes.
So it is similar. Maybe it will help, but we don't still have a full how well it can be sustained after that. So we have no idea. I don't know if anyone has read articles about this. I have no idea.
Okay. So, ma'am, we can read up on that. Ma'am, I have had a couple of adults who came back where their treatment was interrupted earlier, and they came back because they had to change a job. They needed to go to an interview, and they came for only that period of time. Say, interview hua, after that got married, and then there was no follow up. And maybe after 2, 3 years, another interview. And I know I can control it, but a little positive support or some programming from the outside where you tell me, okay, stop now, try using this helps. So these people do come back as adults and say that my parents could not continue the therapy, or one parent was resistant. Something of that does come up later on too, basically. Ma'am,
It comes up.
there's one more for you, ma'am.
Have you used airflow technique with kids, and do you think it could help? Are the kids, according to you, patient enough? I have not used airflow with such small children, but one can always try. And I've used them with adolescents. I've used them with older kids. But I do use a very indirect way of airflow, like even with this child, like I would bounce a ball and say numbers 1, 2, 3. And then I would say, okay, we take a deep breath and then we say 1, 2, do it indirectly. So that sometimes works. So it may work. So you have to try. See, like I say, every child is unique. What will work with one child may not work with another child. So you have to keep trying all the things that are there in your,
in your
bag of
quiver of
techniques.
arrows. Yes, in your quiver of arrows. Absolutely, ma'am. So, ma'am, that was so good. There were so many people who participated in the discussion. This was so nice, ma'am. It was a nice overview of the case, as well as a lot of insights as clinicians ourselves, also the patients, the going back, looking at your goals, questioning ourselves, then counseling, taking up the challenges. So, ma'am, this was very nice, ma'am. So, ma'am, thank you so much for doing this. You got a lot of people chattering, talking, discussing. So this was very nice, ma'am. Thank you so much.
Thank you so much for inviting me. This was a great experience for me to interact after I don't know how many years. that I've actually, had this kind of an interaction. I did present some, I think last year or I don't know where, but there was no interaction. And today there was a good amount of interaction, and I'm happy about that. And that's exactly what I want. Let's, keep having topics where we have discussion, not necessarily a case report.
Yes,
Discussion on one particular aspect, like for example, children with autism, some aspect about it, and what are the different things each one of us would do. So discuss that
correct.
kind of a thing. Have discussions like those
Yes.
also, along with case, of course. So
Ma'am, because we all are doing something. What we all are doing is obviously right. We just need some validation because as practitioners, we do become isolated in nature. So it helps us to discuss, learn, grow, and be validated that yes, this is
definitely,
what is going on. This is what is
definitely.
going on, and this is how we all think. This is how we are shaping as one unit as an organism called as SLPs. So it's great, ma'am, absolutely.
No, I'm very happy that you have started this series, and all the best. And I'm sure it's going to become a popular event for all the
Thank you,
ASLP
ma'am. Hopefully.
who are
Ma'am,
doing private practice. So
yes. Ma'am, so there are a lot of compliments for you, ma'am. Please, please do read it. This chat is later not.
anyway, so thank you everyone for giving me this kind of appreciation. And at this age, it means a lot to me because I was totally out of touch, and I'm so happy that I could present, I could be of some use to you as clinicians. And I always used to say this when I was teaching, that what I want the students to learn is that once they become established clinicians, this what they have learned here should help hundreds of other children or patients. So I think that that's what is important. So that's your series is going to help clinicians really use a lot of information after
Yes,
discussion here,
yes,
and use it
yes.
in their clinics. And I'm going to learn a lot also from the I have yet not had the time to listen to your recordings, basically because of my health issues. See, like right now my ear is giving trouble, that's why I couldn't hear you. I don't know whether it was
Okay.
technology or what, I don't know, but
Ma'am,
that's
it
why
was
I
the
was
network.
having a
Ma'am, it
problem.
was the network. I could see
Oh,
your bars
then
being
I'm happy
yellow.
that it's
So
there.
yes, it was
Nowadays,
the
I get
network,
so
ma'am.
paranoid that, oh, is it my hearing problem that is creating this? And I've not worn my hearing aid because I'm having a little pain. So I didn't wear my hearing aid. Otherwise, it wouldn't have been so difficult. So anyway,
So no,
thank you
ma'am, you
so much.
taking the case online. You handled the case online. You agreed that you'll be doing this on Zoom with me. So, ma'am, it was all in all an extremely wonderful experience. Thank you for sharing. And
Thank you. Thank you so much.
yes, ma'am.
Okay. Okay.
Okay, ma'am. So we'll
Bye.
just wind up here.
Bye, everyone. And thank you for listening and appreciating.
Ah,
Bye
yes,
bye.
ma'am. Bye bye. See you, ma'am. See
Bye
you.
bye.
Thank you. Thank you, everyone, for joining in on a Saturday evening, for your encouragement, for your support, the very stimulating discussion. So, thank you so much. Thank you as a community for showing up and participating. See you all next time. Bye bye.
Bye.